Joining us this morning is Kathy Doitek, who is Director of Emergency Services at ACMC and Ecology. Both? You do both, John?
Both.
Wow. And Amanda Clark, who is Assistant Director of Emergency Department Services at ACMC, Ashtabula County Medical Center. Welcome, girls. It's the first time.
Yes,
Yeah.
thank
But
you.
then I understand you are coming back next month.
We are, we're excited.
Oh boy, it's going to be a tag team. We're going to have
Yep.
special guest co-hosts here on the show. Kathy, how long have you been with the hospital?
For 3 years now, 2012.
Okay. Always been in medical?
No, I actually was in accounting for 14 years before I became a nurse.
Really?
Yes.
And then you decided later in life to become a nurse?
Correct.
Good for you. Good for you. How about you, Amanda?
I've been with ACMC for 5 years.
5 years.
I've been a nurse for almost 13 years.
Really?
Yep. And I've always worked locally as a nurse. So.
Okay. You both live around here then?
I live actually in Eastlake, Ohio.
No kidding.
Yes.
Wow, you got a little
So I drive
ride.
quite a way to come to my job that I love.
I guess.
And I live in Jefferson.
Do you?
Yep.
Okay.
I'm a hometown girl.
Yeah, good for you. Good for you. Tell us about the department that you run, Kathy. I mean, give us, this is like the emergency room, as we call it.
Yes. Through the years, it has been the emergency room. It's been the emergency department.
Right.
So you'll hear ER, ED. And essentially, the emergency department is the doors to the hospital. We see everything. We don't get warning of what we see, what comes walking in the door, what comes in by EMS. We have a wonderful, wonderful staff. In our emergency department, we have board-certified emergency physicians. We have registered nurses. We have LPNs. We have paramedics. We have unit clerks or secretaries. And we do have some techs who can be a nursing assistant or an EMT or just someone that wants to start getting into the medical field working in our department.
Okay.
So it's quite interesting.
Yeah, I guess. And what does your job curtail there, Amanda?
Mine is I assist Kathy with a lot of things. Day-to-day function in the ER, staffing, working on new processes to improve patient flow and patient outcomes. So, anything to better the department and to better the outcomes for our patients.
Well, like you say, emergency rooms, as I call them, that's the old way of talking about them, are utilized a lot in every town that a hospital is located in. In general, do you know how many patients you probably see per year?
We see about 3,000 patients a month.
A month?
A month. Around 2,800 to 3,000 a month.
No kidding. I had no idea it was that high.
With 14 beds.
Wow. And it always kind of stunned me. There's a lot of people, if they hit their finger with a hammer or something, they end up going to the emergency room. Is that because they don't have doctors, or is it because that isn't really an emergency to me?
Right. So we do have two different parts of our department. We have the emergency department, the main department, and then we have a split flow department, which is sort of like an urgent care, a quick care, and express care to see minor injuries, minor illnesses. If you smash your finger with a hammer and you call your doctor's office, they're going to tell you to go to the ER anyways. Typically, they don't do a lot of suturing or stitching in a doctor's office. They can't, handle some of the injuries that we see coming to the ER. So it's not a life-threatening emergency, but they're emergencies that probably cannot be handled by their regular physician's office. So they do come and see us.
Do you have to do a lot of blood transfers as far as with helicopter, by helicopter?
Not a lot. However, we do transfer people. We transfer people for reasons of higher level of care. So if someone comes in and they're a trauma, they got into a car accident that's really, really bad, and they sustained injuries that, could be pretty severe and life-threatening, they would be transferred out. People that are having heart attacks, we transfer out to a hospital that can provide, you know, open heart services or placing stents into the vessels for them. We also transfer out, so the traumas, the people that are having strokes, that can benefit from what they call like intra-vein or intra-artery medication to dissolve the clot. So I always say like a Drano medicine to open that clot up so that it gets oxygen to the brain.
Sure.
But overall, our transfers are probably about, oh gosh, I'm trying to think, maybe about 2% a month.
Oh, okay.
Or less.
That's not real high.
No. No.
You mentioned heart. Obviously, that's probably one of the main traumas that you would get there. Heart attacks.
Yes.
You know. And I know that you have some really good heart people that are employed with ACMC because I've had them on the show. They're excellent. Tell us about, and I know you have a little replica here.
We do.
Tell us about that.
Sure. Well, heart attacks, when someone is having a heart attack, it's called a Stemi. What does Stemi mean? Well, Stemi means ST, elevation, MI, which is a myocardial infarction, which is a heart attack. So you just learned a bunch of medical terminology here. So when someone is having a heart attack, and we call it a Stemi, one of their arteries to their heart is occluded, whether it's partially or fully occluded, so it's not getting oxygen. And so we have processes and best practices in place. We do a lot of education and learning from like certified emergency nurses group to learn what the best practice is to take care of people that are having heart attacks. So what we're going to do is I'm going to have Amanda, you know, take the little heart model here and show you what arteries it affects when you're having a heart attack.
Okay.
So with the heart attack, what it is, it's not actually happening inside the heart. It is, there are, let's see, there's 3 main arteries that come off of your aorta that feed the outside of the heart, which is a muscle. And what it's feeding it is oxygenated blood. So the arteries come down and they feed, there's 2 that come off on this side and then 1 that comes off on this side. And one of these arteries is what gets that clot, which can be built up from, it can be a blood clot or it can be a buildup of plaque, which would be high fat, different things that occlude the artery. So there's, you know, there's, that come off on this side of the heart, and then there's one that's on the right that comes off the aorta here and feeds the right side of the heart. So that's where the artery is. What we're looking at for an ST elevation is we do an EKG, which is we put 12 stickers on your chest, and it prints out a strip of your rhythm. And we're looking at the ST segment, which is a segment on the EKG. If it's elevated, that means there's an occlusion in one of these arteries. And from what part of the ST is elevated is we can kind of anticipate which artery is clogged. So that's how that starts our process for a heart attack and what rolls from there.
That was well put. You did that very well. I understood that.
Well, and I think sometimes when we think of a heart attack, we think our heart has a, you know, like the actual muscle of the heart is what's being affected. In reality, it's the veins that are surrounding the heart that are affected. So it's not like the inside of the heart.
Okay. Okay. I understand that. So that's from your department then that
we detect.
Yes.
Okay, excellent, excellent. Turn it back over to you, Kathy.
Sure. So, speaking about heart attacks and the care provided at ACMC and the emergency department for someone that would be suffering a heart attack, we have a best practice procedure that we do every time. Our times are phenomenal. So if a patient's coming in from the squad, from the community, from EMS, they do that EKG that Amanda earlier spoke of in the squad. It is transferred transferred via electronic means from a system called LifeNet, which was actually purchased for us from the ACMC Foundation. So we get the EKG. They could be in South County, you know, they could be out here in Conneaut. That EKG is transmitted to the emergency department. We look at it. It's the tracing of the patient's heart. We're like, okay, this is a Stemi. We then fax it to Cleveland main campus, Cleveland Clinic. They auto-launch their helicopter to come to ACMC. The squad starts giving the patient aspirin, nitro, you know, things like that. They start their IV, they get to us, we do some blood work, we do another EKG when they get there. We can potentially start blood thinning medicines, and there's several that we can use to start opening that artery up for them to get to the what's called the Cath lab, so that they can go in and they can, you know, put a little stent, it looks like a straw, to open up the artery to give blood to the heart. Likewise, if you walk into our facility saying, you know, I have chest pain or arm pain or jaw pain, or I'm not feeling well, I'm sweaty, I'm short of breath, we do the same thing. And so we get an EKG within the first 5 minutes of you being there. We can see if it's a heart attack, and we do the process. Is there any parts that I may have forgotten in that? I don't think. So once you get to that point and you get transferred, we're going to show you some pictures here in a second as to what happens to your heart and your arteries after the catheterization. So,
yeah. Do we have those pictures?
You can do that right there. You go. There's one.
All right. So if you can see the picture with the first arrow, you can see the artery that's feeding that side of the heart. You can see the first one where it's shut. You don't see any of that contrast or dye coming down to the bottom of the heart. And then after they put the stent in, you can see the artery comes down and feeds the bottom of the heart. Without that oxygenated blood going to the bottom of the heart, that muscle will become weak and die, and then you actually lose a lot of function as an adult.
Amanda, now the first picture shows the vessel stopping.
Correct. That's the before. That's what we see on the EKG. It creates that ST elevation in the EKG, which is what causes us to call the Stemi or the heart attack. You only have so much time truly to open it and have a good result. So that's why time is of the utmost importance, because without opening that, the muscle is dying without the oxygen. So time is very important. That's why we also suggest that if you're having chest pain, you come to the ER right away not wait.
Okay.
Next one.
Next picture, Bob.
All right, and here you can see another one. This one was more partially occluded. You can see where it's like hazy in the middle, but you're not getting a good blood flow all the way to the end of that artery. So this is where they would go in. This one I would probably suggest that they removed a clot. They can actually go in with the catheters, which are like kind of long, skinny hoses. They go to the end of it and they can actually suck out the clot. And then they can place a stent to keep it open, because then that area is at risk for future problems.
You hear a lot about stents. Have they been used a lot? I mean, in the last 10 years, 15 years?
Actually, before I came to ACMC, I've been at ACMC for 5 years, I worked in a cardiac cath lab. So this is what I know well.
Right.
But yeah, so they've been used for a considerable, probably over 10 years now.
Really?
With good results.
I understand that they do get good results from that. Is there another picture?
There's a few more.
Okay.
Just to give you an idea.
And here you can see another, this is where it got real narrow.
See that?
Towards the top of the artery, and then with a stent to open it, you can see the good flow back through. Here it wasn't completely occluded because you were still seeing blood flow and the contrast that came down, but in time it would have completely occluded. And this is actually the right coronary artery, which feeds a big part of the muscle of the heart. This is where if it had completely occluded and we lost all that muscle, that patients would have congestive heart failure, their quality of life would have really decreased after this. This could have been a...
When a stent is issued or when it's put in, do they have to open you up for that?
No, they actually go in through an artery in your groin.
Okay.
And they kind of feed up these catheters and a wire up the artery or up your aorta that feeds to those arteries, and then they over the wire they kind of feed this wire down through the artery, and then the stent goes over top of the wire, and then with a balloon they blow it up and it opens.
Amazing. Is it a long process?
It's really not.
Really?
Because it's been done so much now, unfortunately or fortunately, however you want to look at it. Majority of the cardiologists who do this interventional cardiology are quite quick at it. I mean, it's usually within, once they have access to the artery in the groin, within anywhere from 3 to 10 minutes, they have the artery back open.
No kidding. Yeah. That is amazing. But it comes so far, you know, over the years. Get another shot that we gotta run here. Here you go.
Okay, and here's another one where you can see this one was completely occluded. So the before you see that kind of a stump of the artery, and then after they were able to open with the stent, then you can see the flow all the way down to the tip of the heart. It really, I mean, it makes a huge impact in people's lives.
Sure.
So,
are the patients alert? Are they awake when this is done?
they do what they call a conscious sedation or a moderate sedation. It's
just put you
it's
in.
like a twilight. It's the same kind of stuff that you would get if you had an endoscopy or a colonoscopy, those kind of things. So you get a little loopy. You don't really care what they're doing, but it's not painful. Truly. There's not.
I like non-painful.
Right. In the inside the artery itself, there's not nerve endings, so you're not going to feel that.
Right.
Gotcha. Interesting. Is there one more? That's it?
Yeah.
Okay. Interesting. I've never seen that before. We've never shown
and then we're also chest pain accredited, which means, you know, we have to meet certain guidelines. We have to provide certain care for people that are having heart attacks. The average door, meaning the time the person comes in the door to the time their artery is open, like we showed you in those pictures, is 90 minutes for hospitals that have a cath lab in them. Because we are so far away from any of the hospitals that have cath labs, have a 120-minute door to opening the artery. And we've been as good as 74 minutes in some of those pictures that we showed you. 80 minutes, 91 minutes. So even though we're so far away from this intervention for our patients, we are so perfected in our process that our outcomes sometimes are better than the ones that the people go to like main campus Cleveland Clinic for. So we're very, very proud of that. Very proud of that. And kudos to all my staff.
Right.
Sure.
And I do want to say that there is 2 types of cath labs. We do have a cath lab at ACMC, but it's non-interventional. It's just diagnostic. You would have a cath there if you're not having active chest pain, if you're low risk. These patients are extremely high risk, obviously, because they're in an acute heart attack phase where so you have to go to an interventional cath lab, which does the stents and that kind of stuff.
Which would be the clinic?
The Cleveland Clinic is who we usually use. We can send to other hospitals if the patient requests.
Right.
But yeah, that's the.
Okay.
So I don't want to say
Very interesting.
Very, very interesting. Yeah, I can remember as a young reporter with the Conneaut News Herald, they sent me on a story for a thing. I think it was called Mended Hearts. This is back in the early 70s, and that was just beginning then. And this was people that had open heart surgery back then, and that changed their lives for the better. That's what we remember back in the early 70s. Since that time, it is amazing, from speaking to all the doctors and nurses that have been on the show, how far heart surgery and heart lifestyle changes have changed since those days. It's amazing.
Yes.
You know, all for the better.
Yes.
All for the better. I think it's fantastic. Do a tremendous job, girls, and do a great thing for our county. Now you're going to come back and you're going to talk about a subject that I think is really, really timely. Summer injuries.
Yep.
There's going to be tons of those out there.
Correct. So
we're
we're going to try and prevent some of them.
I almost had to consult them this morning. I got bit at a picnic the other night, and didn't see the next day. It was all like a mosquito bite type thing, And then I got other bites, so there must have been all kinds of bugs out there that night. But that's what you get this time of year.
Absolutely.
Things like that. So you'll be talking about bicycle accidents, all that sort of stuff.
Right.
And I imagine you get a bunch of those in the summer.
We do.
In wintertime too. People falling on ice.
Yes. Wintertime, the ice is
I hate
very
it.
big. I hate it too.
Absolutely hate it. So you'll be coming back about a month, right?
Yes.
Excellent. I think that's really timely. I think that we need to discuss that. And one of the things also I hope that you do touch on, because it's a problem that hits this area a lot in the summertime, heat stroke.
We can do that.
That can be so dangerous.
Very dangerous.
So, okay, that'll be good. That'll be good. Thank you, Amanda. You did a good job today.
Thank you.
Appreciate it. You too, Kathy. Appreciate it.
Sure, you're welcome.